even though there's going to be a little bit of overlap between my talk and some of the other people, I think we were just talking about the fact that repetition is really good, and you get a different way of thinking every time you hear somebody else talk. So hopefully the way I look at the great arteries and venous connections maybe inspire somebody else to think similarly, but we'll walk through sort of what my approach is to evaluating these, along with a couple checklists I've provided for just things to cross off your list to make sure that you've looked at. So I have the same disclosure today as I did yesterday. So we're going to start with the outflow tract views. Everybody, I'm sure at this point, realizes that there's two of them, an RVOT and an LVOT, but how you ascertain that those are normal and originate from the appropriate ventricles means you have to kind of walk yourself through a list of morphologic characteristics that are important to assess. So obviously, for one, the RVOT, a normal right ventricular outflow tract, originates in the anterior or right ventricle. I always mentally look at the semilunar valve, which in most cases is a pulmonary valve, to make sure that it doesn't look thickened or dysplastic, and to make sure that you see it disappear during systole when it's open. So, it's fairly easy to see as the clip is running, but if you're not sure, just cine loop through your clip and make sure there's a period at which you don't see the valve at all, and that generally corresponds to a normal valve. The normal RVOT starts anteriorly and in a normal configuration arches back towards the left side of the trachea where it becomes the ductal arch. Now, what do people typically refer to when they say the RVOT is normal? They talk about it bifurcating. Well, just as a word of caution, this image, yes, it shows a bifurcation. This is going to be the right pulmonary artery as it comes around behind the aorta and superior vena cava. But this may not be the left pulmonary artery. So be aware of the fact that this is typically the ductus arteriosus. In the middle here is where you're going to see in real time the aortic valve sort of staring at you en face. So you can also evaluate the number of cusps that you see in the aortic valve as this clip is running. So here, people talk about this as being rabbit ears or bunny ears. We see a bifurcation to the RPA, and in this case, the ductus. Now, the left pulmonary artery lives in a very similar plane to the ductus arteriosus, but beneath it in sort of a caudal cephalad plane. You can distinguish them on an axial view because the left pulmonary artery tends to have a little bit of a squiggle to it before it goes to the left lung, whereas the ductus arteriosus will shoot straight back. So interestingly, when you look at this view, the LPA is probably beneath the plane here, squiggling underneath this ductus arteriosus, and what you're seeing in this view is the RPA and the ductus. Now here's a view that actually shows you what really happens, which is, and I got this question as a text message from a former resident of mine a couple weeks ago, is it's not really a bifurcation, it's a trifurcation. You have the pulmonary trunk that gives off the LPA and RPA, and then a third branch, which is the discrete ductus arteriosus. And if you look in the short axis view here, you can see how they live right on top of each other. So ductus, which is a little bit larger than left pulmonary artery. And you can also pick that up really with color compare nicely. So here's again is another good clip showing the bifurcation and then coming to the pulmonary arteries, and then coming up into the ductus arteriosus. So when I got this question from him, he sent me a picture that said, is there such a thing as an anomaly where the pulmonary artery trifurcates into 3 branches? And I said, well, technically they all do. Remember, there's 2 pulmonary arteries and a ductus arteriosus. And I'm doing all of this by text message with images, and I said, did you get waveforms on them? And he said, yes, they're all arterial flow. And I said, well, I expect that's the case, but you can distinguish a pulmonary artery from a ductus arteriosus by the appearance of the waveform. So if you're not sure which is which, just sample them as you would with any normal Doppler gate. A pulmonary artery is an extremely extremely high resistance circuit in the fetus. So the time to peak velocity, or the period in which this waveform reaches its maximum velocity, is very, very short, because you're like running into a headwind. You hit your maximum speed really quickly. So if you look at the time to peak velocity in a pulmonary artery, it's only 35 milliseconds. It's really pretty short. But if you do the same thing in a ductus arteriosus, you can see it's got a more gradual, I mean, it's still fairly abrupt, but a more gradual time to peak velocity, close to 3 times as long. So if you're unsure which vessel you're sampling, remember what the waveform of a PA looks like versus the ductus arteriosus. So that was my good deed via text message for fetal cardiology recently. So when you're looking now towards the vessels as they come up into the chest, into the 3-vessel view, the pulmonary artery and ductus should arch, as I said, back towards the left fetal shoulder and meet in a V shape towards the left in the terms of the 3-vessel view. And we'll get to that more in just a minute. Moving on to the LVOT, I think we all have views cardiology-wise that have sort of been our kryptonite and where we've got burned in the past. And this is one view that I would encourage you all to sort of mentally make sure you get. You can get views of an LVOT that show it's an aorta, that show it originates from the left ventricle, but it's really only this view that helps you exclude a subaortic or malalignment defect like an overriding aorta. And the important thing in this view is that you have contiguity between the ventricular septum and the anterior wall of the aorta. So this is referred to as the long axis view or the 5-chamber view, but it's the one view that I sort of force myself to make sure is normal when I'm looking at an LVOT. And that's in contrast to an image like this. So here we have the ventricular septum, here we have the anterior border of the aorta, and here, in a very similar sense, you see we have this offset. There's no contiguity. Why do we have this break here? Well, that's because the aorta is anteriorly malaligned or overriding the ventricular septum. So not having that view or having it normal would be able to exclude this particular finding, which is, tetralogy, subaortic malalignment defect, even, this appearance can be a truncus. The flow through the LVOT should be laminar. Similar to the RVOT, you should not see any increased turbulence or aliasing distal to the valve, which may indicate valvar stenosis or early obstruction. Again, paying attention to this view here. And when you get the LVOT, this is a slightly more oblique view, you're going to want to see it head off towards the right shoulder to a distance before it curves back to become the transverse aortic arch. And it's going to become the transverse aortic arch rightward of the ductal arch. So here we're sort of sneaking up into our 3-vessel view a little bit. Here's the trachea, here's the superior vena cava, but the aorta swoops towards the right a little bit before it turns back. That's another important clue. What if you see this image? Well, here we have ventricular septum. It's contiguous with the anterior wall of the aorta. What about this image? Did I just tell you may not fit right? It should go a distance before it swoops back as the transverse aortic arch. So if I show you this clip, do you notice anything about it that doesn't fulfill that criteria? What about this before it turns back right here? Well, what if I showed you this one? It's tricky, right? But it's a super important abnormality to exclude. Or this one. Or how about this one? Any left outflow tract that immediately curves back behind the left atrium should make you suspicious for a transposed pulmonary artery. And this is the left pulmonary artery. So again, train yourself to look for an aorta that comes out to about here before it comes back as a transverse arch. I also try to get the aorta in the longitudinal direction where you can see the head and neck branches. This is a little bit quirky, and we'll go over that one in another talk. And also using, HD flow or something that picks up flow in vessels that are at extreme angles of insonation, you can fill the head and neck vessels nicely on a longitudinal arch. Now, confluence of the ductal and aortic arches actually used to be a little bit of a struggle to show people three-dimensionally, but since we now have this radiant flow, which adds dimension and depth to vessels, you can see here how the ductal arch meets the descending aortic arch right here. So that's the confluence of the arches, and this would be where we're seeing the tip of the V in the three-vessel view. I used to have to use this diagram to show it. Again, it's a 3D rendering that we're rotating where you can see the confluence of the ductal and aortic arches, and this little dude squiggling under here is your LPA. All right. So looking again at the vessels, the outflow tracts, a sweep is really helpful to make sure that you see all of these things come out in the order in which we've just described them. So from the four-chamber view coming up into the PA bifurcation, ductal arch, and actually as we go back down, you'll get the view of the LVOT over here. So a sweep in an axial plane above a four-chamber view is going to be really helpful in proving normal anatomy of the outflow tracts, as well as three-vessel view and crossing of the outflow tracts. So if you're not comfortable doing that, acquiring a sweep that at least proves that the outflow tracts cross is really important. And this is important because there's some permutations of transposition, depending on the spatial arrangement of the vessels, that can give you almost normal-looking discrete RVOT and LVOTs, but those vessels are always going to be parallel. If you can demonstrate them crossing, you've gone just that one step further to proving that they're normal. And you can do the same thing with color flow. If you keep the apex to the side at about, horizontal, one vessel going one way will have a red signal, the other one will have a blue signal. So confirming they cross by having discrepant color signals is also helpful. All right, so checklist for interpretation of the outflow tract views. Morphology is important to prove that they originate from the appropriate ventricle. So this can get a little bit tricky with certain other abnormalities that we're going to talk about much later, like congenitally corrected transposition. But the vessel that you want to see arise from the right ventricle should bifurcate/trifurcate, depending on your terminology. The anterior origination of the MPA with bifurcation should be visible. How do you prove something's a pulmonary artery? It has to split into at least one PA and a ductus that you can see, or the two pulmonary arteries. The ductal arch should be seen anteriorly in the chest and confirmed to meet the descending aorta. And again, it goes without saying that these should have sort of laminar flow, anterograde flow by color flow if you choose to use that. In the LVOT view, the anterior wall of the aorta needs to be contiguous with the interventricular septum. How do you prove that something's an aorta? Well, number one, it doesn't bifurcate, but you prove it's an aorta by showing that it has head and neck vessels originating from it. So when you get your longitudinal view, the aortic arch, which people refer to as the candy cane, starts in the mid-thorax, has that candy cane appearance, and demonstrates head and neck vessels. That's how you know it's an aorta. So for instance, if you have what you think is a ductal arch that demonstrates head and neck vessels, largely speaking, that's probably an anterior transposed aorta, not a PA. And finally, demonstrate crossing of the outflow tracts in one of the techniques that I've just shown you. Finally, adding the three-vessel view, I'm not going to put too much in this, which will show you arch laterality with respect to the trachea. So you can interpret whether there's a right arch, a left arch, etc. I don't want to steal the three-vessel view talk, so I'm going to cut it close there. All right, moving on to venous connections. One of the things that always, I don't want to say puzzles me, but I sort of kiss the ground that this never bit me more than it ever has, is when you think about people learning to image hearts, we all become very, very focused on outflow tracts, LVOT, RVOT. Now they're included as required views. But it's mortifying to me to think of how many years I never spent looking at venous connections or proving normal venous return, when some of these abnormalities, specifically TAPVR, can be more lethal than some of the outflow tract views. So the next half of the talk, I'm going to implore you to train yourself to look at the veins, because they can be clues to significant abnormalities, even for things like heterotaxy or just other syndromic issues. So not to belabor this, because I know this has been shown previously, remember that in venous embryology, we start out with a paired or symmetric arrangement, and very similar to what we see later on later today with aortic arches, there's variable regression of either right or left structures, depending on which side we're looking at. So typically, it's the right umbilical vein that regresses, it's the left superior vena cava that regresses, et cetera. So the final venous anatomy is the product of regression of some element of the paired symmetric structures. So the intraembryonic venous circulatory system, like we said, is paired. We talk about cardinal veins as being SVC and IVC, superior and inferior cardinal veins. So looking at the configuration of those two vessels is helpful to understanding venous abnormalities. And again, they may be isolated as part of caval abnormalities or bigger spectrums like heterotaxy. So again, using our axial plane, this would be the plane of the four-chamber view. If we move just a little bit higher, we get to the standard three-vessel view. And I'm only going to use this to show you that it's the simplest way to assess the location of the superior vena cava. If we get a little bit higher, where we also incorporate the transverse aortic arch, we have the three-vessel tracheal view, but again, the implication for venous screening is that it's going to show you where the superior vena cava lives. Knowing that this is the left side of the fetus, an SVC living to the right of the aortic arch is a normal right-sided superior vena cava. And that's what we're going to see here in this clip. So oftentimes, just because remember it's going to be coming directly into or away from you, you're not going to fill this with color, but you should see it as a sonolucent structure just rightward of the transverse aortic arch. Remember also the other normal venous anatomy that lives just above the three-vessel view, which is the brachiocephalic vein. This is the vein that drains the left upper extremity and comes across in normal anatomy into the superior vena cava. Now again, this can depend a little bit based on the configuration of the SVC. If you have a left-sided superior vena cava, typically this will come from the other side. So slightly higher in the chest, this more hypoechoic area right here is the fetal thymus. You can see that this is venous by a couple reasons, not the least of which is it varies with fetal respiration. So here's the brachiocephalic vein coming across the fetal chest, draining into the superior vena cava. And as mentioned yesterday, there's some variations to this. Here's an intrathymic brachiocephalic vein. Not important necessarily, other than you should look for it as normal anatomy. Again, a normal venous structure at the level of the three-vessel view is the azygous vein. And what this is a vein that runs from inferior to cephalad and comes towards the superior vena cava as, technically speaking, another transverse arch in the upper chest. But this is different in the sense that it drains towards the SVC, right? Your other arches, the flow is going to be this way. So it's something that you're going to see typically as you're looking in the three-vessel view. And, part of the reason I point this out also is for you to realize that this is a normal structure. I get referral for these things sometimes where, extra vessel, not sure what it is it a vertical vein? This is a normal azygous drainage into the superior vena cava. Here's another one. And here is the view of the azygous arch longitudinally. So here's our bicaval view, where you can see this small paravertebral vessel coming and draining forward into the SVC. At the level of the fetal abdomen, you should also look at the location of the inferior vena cava relative to the aorta and the stomach bubble. So here's the fetal spine, stomach bubble over here, so here's left and here's right. I've taken this as a rendered view and twisted it, but it shows you that the color signals are in opposite directions, which is important to distinguish, arterial flow in one aorta, descending aorta in one, and inferior vena cava in the other. Bicaval view is important as well to help you rule out interrupted IVC, any aberrations in caliber or size, and those can be helpful clues for other things. So in fetal life, the bicaval view is pretty easy to get. You have your right atrium here, superior vena cava, inferior vena cava, and they can be obtained in one linear longitudinal plane. You should mentally look at these to compare their size. They should both be of the same caliber in fetal life in normal venous configuration. What if they're not? Well, it's actually, you gotta walk yourself through a pretty simple algorithm. If one of them is increased in size, logically it's getting more flow. Where is it getting more flow from? Is it getting more flow because you have something like an AVM of the head or vein of Galen aneurysm, which is loading the superior vena cava? But it can also be a powerful tool for picking up anomalous venous return. The variations, the more common variations are supracardiac or infracardiac. Either of those will either volume load the SVC or the IVC, relative to what the type of abnormality is. So make sure that you see them of similar size. And here's a clip showing that they're pretty easy to get with normal venous flow. The ductus venosus is another thing I'm going to make a plea for, especially to look at it in the first trimester, which I do for all my nuchal translucency screenings, only because it's so unbelievably easy to get in the first trimester. And remembering that this is one of the fetal shunts. So what the ductus venosus diameter is about a third of that of the umbilical vein, designed to bypass the majority of the portal circulation to the inferior vena cava. Well, why does it do that? Think of where the most highly oxygenated blood is in the fetus. It's coming in the umbilical vein, right? So you want your most highly oxygenated blood to be shunted to the organs that you need most, which are your brain and not necessarily your liver or your gallbladder. So what the ductus venosus does is it functions as a restrictor. And this is actually the best diagram I can give you to explain what this does. It's like putting your finger over the end of the hose. You accelerate the velocity of the blood or the water that's coming out of the end of the hose. So what this does is create a higher velocity stream of very oxygenated blood into the inferior vena cava, where it tends not to mix with the lower velocity and lower oxygen blood that's just returning from the inferior or lower part of the fetus. And this high velocity stream remains separate as it enters the heart, where the high velocity, high oxygenated blood is then shunted across the foramen ovale to be able to go right to the fetal head. So that's preferentially streamed into the left atrium via the second shunt, which then goes to left ventricle, aortic outflow tract, head and neck vessels. So the normal appearance of the ductus venosus is a mid-sagittal view of the fetal abdomen. Here, as Alfred described yesterday, is the vestibule of the inferior vena cava. If we follow this out to here in a color box, you would see that this is actually the umbilical vein that comes in here, and you can see right here where it narrows down. The way to be able to find this or sample this is to use this little bit of aliasing where you start to see the flow acceleration as an indicator of where you should put your Doppler gate. A normal ductus venosus waveform will look like this. Now, the A wave velocity varies a little bit depending on gestational age. The earlier you are in pregnancy, the lower the A wave velocity. But nonetheless, there should always be anterograde flow through the whole ductus venosus waveform. And these, because it's a venous form, will have pulsations that are retrograde reflections of cardiac activity. So you'll have a systolic peak, diastolic peak, and the A wave or trough. What the A wave is telling you is basically a surrogate of central venous pressure. How much is that atrial contraction causing a reflection in reduced flow in the venous system? Now, the ductus venosus can also be obtained in an axial plane here. You look at the umbilical vein coming in, again, curving towards the right portal vein. The ductus venosus will come off right about here and shoot straight back. But the longitudinal view is something that if you look at every 12-week fetus and get that view, you'll be stunned at how easy. It's one of those things in like imaging and medicine that you think is so hard you'll never be able to do it, and the real secret is it's actually easy. Finally, we're going to move to, again, one of my other kryptonites, which is pulmonary veins. So, only because Norm Silverman has been a huge mentor of mine, and he's incredibly blunt at times, he taught me early on in life, in my cardiology life, that anomalous venous return plus intact ventricular septum equals dead. So that's kind of a powerful thing to have hanging on your head when you're looking at fetuses that may be delivered at outside hospitals where nobody's going to pick up on the fact that they're cyanotic or have any other issue. So, as a good rule, you should make sure that you see at least one right and one left vein returning to the left atrium. So remember, they're going to drain towards the left atrium. So the upper one, using this view, will be blue, the lower one will be red. If you do it in an apex up position, you can actually train yourself to see 4 of them. The 2 upper pulmonary veins tend to come forward, so think of them as they're hugging the heart. The 2 inferior ones tend to extend more posteriorly, and that's where you're seeing the difference in color signal here. But they're all draining towards the left atrium. Here's another view of this. So 2 over here, and at least 1 over here. Now, how do you know they connect to the left atrium, right? You can have a venous confluence behind the left atrium that, particularly in grayscale, is going to look for all the money in the world like it connects, but it may not. So think again of the ductus venosus rule that I just told you about. If something is connected to the heart, you're going to have retrograde transmission of cardiac impulses. So the way to know that a pulmonary vein is connected to the left atrium, and this is the waveform down here, is to see the same systolic, diastolic, and A wave. If a pulmonary vein is not connected to the left atrium, it's incredibly unlikely you're going to pick up transmission of an atrial impulse in a pulmonary vein. So it's one thing to see them, it's another thing to prove they connect by showing that you have an A wave. So finally, checklist for venous return interpretation. At the level of the 3-vessel view, the superior vena cava should be on the right side of the chest, returning to the right atrium. The brachiocephalic vein crosses anteriorly in the chest and drains towards the superior vena cava, whichever side that may be, typically right. Identify the azygous vein, which is best in the 3-vessel view, although you can also see the arch, just so you become familiar with its anatomy and realize that it's a normal structure, and realize when it's abnormal in certain other cases. The inferior vena cava should be on the right side, juxtaposed, meaning on the opposite side of the fetus to the aorta. So the aorta should be left-sided, the IVC should be right-sided at the level of the abdomen. The bicaval view should show both IVC and SVC entering the right atrium and similar in size. And finally, this view allows you to confirm that the IVC is continuous through the liver and not interrupted. You should confirm that the pulmonary veins return to the left atrium, and again, prove that connection by documenting that you have an A wave in the pulmonary venous waveform. Look at the umbilical vein orientation at the level of the abdominal circumference and confirm the presence of a ductus venosus with an appropriate waveform. Thank you.